Hi, my name is Max Wieske, and this is my presentation on special considerations in emergency care. So this is my trigger warning. My topic and what we're going to be talking about today is caring for adult patients with a suicide risk. If suicide is a very traumatic topic for you, we're going to be talking about it during this entire presentation, so you are welcome to turn away now. However, I do want to encourage people to stay and listen and watch because while this topic can be triggering, it can evoke certain emotions and memories, it's often stigmatized, which naturally makes it a very important topic to address as nurses. Getting into things, these are the topics we're going to be addressing, and we're just going to go ahead and get right into it. Starting off, I just kind of want to go over some quick important facts as to why suicide needs to be addressed. So it is the second most leading cause of death in the US for ages 15 to 34 and the 10th leading cause overall. The most common cause of suicide is an underlying mental illness, um, or sometimes they don't have a mental illness at all and they just have some warning signs like increased substance use, isolation. But as nurses, these warning signs may not be present in our care. These may only be seen outside of the ED, which makes screening tools that we're going to be talking about very important. Um, there's some other topics here, but the absolute most important one to know is that 36% of people who die by suicide have visited an ED within a year of their death, which means that people are coming in, they aren't having their holistic care addressed, their suicide risk assessed, and they are passing away, which makes addressing this topic important. That is where evidence-based tools for suicide screening come in. The ED is often chaotic, which means we need a quick, effective, minimally disruptive tool to help in the ED and address this topic. Luckily, these tools exist. Starting with our first one, we have the AQS, the Ask Suicide Screening Questions. It is a primary screener that is developed by the National Institute of Mental Health. Primary in this case just means that it's the first tool that is given to patients. It's no matter what their risk or precipitating factors may be, they're going to receive the same tool. 4 quick questions, typically takes around 20 seconds to administer. It can be used in any patient 8 and up. It's brief, fast, perfect for the ED, doesn't interfere with primary medical care. They can just be given it, fill it out real quick, and continue on. It's a fantastic starting point, fantastic tool for what it is. Another tool that we have that might have some other aspects that the other one misses is the CSSRS. It's widely used. It has over 150 languages, which makes it very universal. It's peer-reviewed, easy to use, and it acts as both a primary screening tool, which was mentioned earlier, and then a secondary screener, which means that it's basically assessing severity and immediacy in a patient, as well as just their overall risk. This really helps us quickly decide the support and treatment a patient needs regarding suicide risk. One critique of this, however, is that it doesn't focus a lot on precipitating factors and some things like trauma or social stressors, which is where our second and last tool comes in, the ESS. This is only a secondary screener and is only used after they are tested positive with the suicide risk with the aforementioned tools. Helps evaluate other risk factors beyond what was previously addressed in the first tools. It helps us better tailor treatment and interventions more appropriately. It helps us dig deeper into cases where it might not be as clear. So treating patients ethically, we have our ANA guidelines as a foundation, but some of them are much more important than others. So justice, we're treating all patients equally, equitably. We view them no different than another, regardless of any psych history or how they're presenting in the ED. Each patient should receive the same screening tool. And then treatment should be based on the results of that and facility policy. With beneficients, just be nice to your patients, non-judgmental. It's a trauma-invoking topic, and so using open-ended questions, non-judgmental language, it can really help aid the process of screening. Also, just providing education, like the 988 number, which is the suicide crisis lifeline number. Now, the most difficult topic to address, not the most important, but most difficult, is autonomy. We're going to address that much more in the next slide. But patients have the right to refuse care. They're themselves, and so they can decide, do I want to be admitted for this, or do I want treatment or not? Um, the biggest, most priority guideline to follow here is non-maleficence and patient safety. So patients need to stay safe when they're in our care in the ED. This basically means that if they're found to be at risk, we are following facility protocol to address that risk. This may be just one-on-one monitoring with the patient, or it may just be admitting the patient to a room that decreases the risk of self-harm. There's not a lot of items in there. And a safety plan should always be developed before a at-risk patient is discharged. This just basically means if they feel like they want to commit suicide, they have strategies and resources at their disposal. Now, to address patient autonomy, we need to talk about the legality. This is basically regarding the third situation here, which is when there is suicide risk and not asking for help. With this situation, we're going to be doing our involuntary admission criteria, but with the other two previous situations is basically just your average patient accepting treatment. So let's get into involuntary admission criteria and a fine balance basically between autonomy and safety. So this is when we are admitting a patient to a hospital against their will. We're overriding their autonomy in order to prioritize their safety. It's very serious. It has those three very specific guidelines, at least in the state of Oregon. And the Supreme Court has these national rules and protections regarding involuntary admission, because if you are overriding a patient's reason, you need very specific guidelines and rules to follow when doing so. And it's all basically meant to aid in patient care, keeping them safe and treating them properly. Additionally, there's some other factors like two physicians need to agree and certify that the criteria met. Patient has the right to court and to legal counsel. And basically, this is all in the name of prioritizing a patient's ability to speak for themselves, while also getting them treated in the safest way possible. How are we as nurses supposed to advocate for social justice? As nurses, we are responsible for educating on health topics, and suicide is one of those topics. And so, to provide a meaningful education, it's important to recognize that suicide doesn't affect all populations equally. We have all these risk factors, like men are 4 times more likely to commit suicide, 23.8% of suicide were among non-Hispanic American, Indian, Alaska Native people, and more facts that just kind of show who's at risk and who's not. As nurses, we need to be able to have these open conversations with patients regarding suicide. There's a lot of feelings regarding this topic, regarding mental health, suicide itself. So, cultural disparities, any kind of misconceptions, they need to be addressed on a national level in order to change how we approach mental health care. We need to be able to provide support for patients who are at risk. That includes equitable access to all sorts of treatment and care regarding mental health and suicide. And so it's all in the hope of having patients stay safe, be informed, and know about the tools at their disposal, like the 988 suicide crisis hotline, and then teaching people how to act when they suspect someone may be committing suicide. Um, and why is this so important as ED nurses? Why do we need to address this topic? Well, screening tools and strategies, like the aforementioned, help to significantly improve like workflow and just patient care overall. Just properly assessing patients and treating them appropriately helps with resource management and using them effectively. The ED serves a wide variety of patients, and screening tools help provide care that's holistic, standardized, and using the right resources for the right patients. The most important reason is it saves lives. We are assessing these patients earlier, we are addressing the issues earlier, which helps to improve patient outcomes and keep them safe. And that's my presentation, and thank you for listening.